Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And this is of a patient whose right ear procedure I previously uploaded. I will just get that video number up for you guys so you can watch. And I did say I'll upload their left ear video afterwards. Just bear with me, I should have actually got that prepared beforehand. So this patient has to attend every year to have crystallized dead skin peeled and removed off their ear canal and their eardrum. You can see here I'm using the right angle correct, which has got a tapered and curved tip to just lift this skin off the posterior canal wall. So it's video number 1578, and that was of their right ear. So I've just used some medical grade olive oil here. And I'm almost using the correct as a wallpaper scraper or a spatula almost, if you like, just to separate it. And now that I've got it off the canal wall, I think I'm going to use the forceps. I'm just going to be careful I don't touch the anterior canal wall, which is the left-hand side of the ear canal with the left-hand side of the jaw. And I've peeled that. And when I peeled it, I thought all of it's going to come away in one piece. But there's still a thick layer of skin on their eardrum. It's not visible at the moment because this patient's got a lot of oil in their ears. I'm just going to suction the excess oil out. Now, at the entrance of the ear canal, they had quite a few protruding terminal hairs, and they were coated with the oils, although we tried to dry those hairs up. So every time I was going in, I was trying to avoid the tip of the endoscope smearing against some of these hairs, but some of these hairs were a bit difficult to avoid, as you can see. So if we're putting the instrument in, so it might be slightly blurry. Well, I wouldn't say blurry, but for the viewing aspect anyway, it may not be as sharp and clear as some of you may like, but it wasn't deterring me in any way from removing this. So I've just gone back to the suction here. I'm going to the top part of the ear canal, although it looks on screen as though it's the left-hand side, but this patient's ears, the head slightly tilted forward. So that was more kind of the top of the ear canal, slightly maybe to the front as well. So the eardrum is there. So again, just going right to the roof of the ear canal. You can see the skin, it's semi-detached, but we've got to be so careful because we're right up against the patient's eardrum and we're in the bony part of the ear canal. Now this patient comes regularly, so they're very comfortable with the procedure now. Some patients probably would find this quite a difficult procedure because we're right up against the eardrum, and I was having to apply a bit of pressure. So this skin, it's failing to migrate. This skin should naturally start to migrate sideways off the eardrum towards the entrance of the ear canal, and as it reaches the ear canal, this sheath of skin, all the individual skin cells that form this sheath, should then begin to separate and flake away. But in this patient, the skin fails to migrate, and it instead lines the eardrum and the ear canal, the medial aspect, the inner half at least. And the net effect is that this thickens the patient's eardrum. So the eardrum isn't as mobile, and they notice reduced not only volume in speech but clarity. So when you've got an eardrum that's stiffer than usual, which of course this would cause a bit more stiffness because it's thickening the eardrum, that generally affects the transmission of low frequency sound. And if there's increased mass, if the weight of the eardrum, which again this will contribute to some increased weight because it's a thick layer of skin, that generally affects the transmission of high frequency sound. So low frequency sounds are typically the vowels in speech, and the vowels provide us with the volume, whereas the high frequency sounds, they're the consonants, the beginnings and endings words, which give us the clarity. So this patient is noting both a reduction in volume and clarity in speech. So just gone back to the front part here, and this skin, it's quite difficult to sometimes see. Although it's crystallized, it's very thin, and some parts were transparent. I think there was just a tad remaining on the eardrum right at the end, but it was very hard to see whether that was skin or not. I was applying a lot of pressure, so I decided to leave it if it was, but So we can see half the eardrum. You can see the posterior parts of the back section between 12 and 6. There's a bit of oil there that I've inserted. That's just sitting in the inferior recess. We'll get that out in a moment. And you can see the colour difference. So we're right up against the eardrum. This is where the hammer bone is. So again, you've got to be really gentle. And I typically find at the centre of the eardrum, the umbo, that's the progenitor site. That's where all the skin cells that are formed in the ear originate from. So that umbo region, typically the skin is normally a lot more crusted. It's a bit more difficult to peel away. So I've just gone back to the front section. And the difficulty with the skin is as you start peeling it away, it wants to flex back. So you may have seen that. I lifted it off, then it flexed back onto the canal wall. So again, going right up against the eardrum. This is the umbo region. I want to like push almost the skin from right to left. I'm applying a bit of pressure on the eardrum. I almost have to slide this off. It wants to come away, but it's the centre part of it's really adhered to. So I'm just re-evaluating. I'm going to try going to the front part of the ear canal, see if I can peel it from here and go inwards. Now, although these suction tips are deburred, so all the sharp ends are removed, it's still a stainless steel capillary tube, and we're working basically directly on bone. So there is some skin there, but it's very thin layer of skin, about 0.1 millimeters in thickness. So we've got to be careful not to stab in. Now, I'm using the right angled ear hook here. Now, because it's an L bend, very unlikely, or if you use properly, the tip of the hook is not going to penetrate into the eardrum. So we rested the flat side against the eardrum, and I wasn't actually attempting to remove it. I just wanted to help slide this off. So it did help to somewhat separate some of the skin, but I'm going to go back in now and start peeling again. Still quite tricky, but you can see it's coming away a bit easier now. I think there was just a bit of hair there, so I just took that off and going back in. Again, when I'm inserting the endoscope, I want to try and avoid those hairs, so I'm kind of meandering around it. Some of these hairs got trapped as I went back in. So again, just near the umbo, I'm going to start peeling. Just go to the top of the ear, I'm going to peel down, and now it's starting to come away. I've got a little bit out there. But there's still quite a lot of skin there. It may not look like it, but you'd be surprised how much we eventually remove. So we go into the anterior section of the eardrum. Oh, no, I'm going back to the middle. So here, it appeared to be some skin, but there was some, but I think there was just some of the skin that I peeled away earlier. It left a little ridge there. So it had a bit of a false appearance. Again, just going into this umbo region, I'm going to glide down and to the left, and fortunately I just about managed to get this away. It's just stuck in the anterior and it's just flexed back. That's what this skin can do. And we're using a really ultra fine. I'm using a 19 gauge one here, so it's very quiet as well. And it's less traumatic, so you're less likely to cause any trauma to the eardrum using a smaller fine end. But you can see it's causing me a bit of a problem, this. Just trying to glide against the eardrum. We do eventually get this. I just think I'll just put some more oil in. Just going to soften the skin a bit more. I'm hoping some of that oil will seep in, because I did initially lift it with the ear hook. That some of it gets in behind the skin and the eardrum, although I've put quite a lot of oil in already. So I'm just suctioning the excess. There we are, I've managed to get that away. So it's quite a big piece there, surprisingly piece. Now, this skin, if we didn't remove it, it wasn't going to naturally migrate. This patient's aware they're going to have to tend on a regular basis. Their migration, for some reason, has just halted. Sometimes a migration can halt if a patient's had radiotherapy around the ear or the head, for example, because that can damage the blood vessels, which then means reduced blood flow, and it's the blood flow that helps stimulate the migration. It's almost like the fuel behind the migration. So just getting some of the excess oil out from the inferior recess. See here, it looks as though there's some skin there. As you can see that ridge just where I am now, but I think it was just a false appearance. And it's just a little flakes here and there. I'm just going to come back out. I think I'm going to work more on the midsection of the ear canal here. There's some skin just there. I'm just going to get underneath and lift it away. This bit's just on the cartilage, so I can apply a bit more pressure. So this patient's main symptoms not only reduced hearing, but they're experiencing a lot of itchiness and irritation. Just going to focus on the back part of the ear canal. So here, the endoscope's actually just near the entrance. It's probably not even entered the ear canal. It's just on the outside. And I want to glide the suction tip in the same plane as the canal wall, so we're not stabbing into it. And again, quite a lot of skin came out here, surprisingly. I'm just going to re-enter. Just trying to get that hair away. I'm not sure if that did come away though. Just because it's quite oily, it's sticky. It's not going to cause a problem, mind you. And I just want to see if there is some skin I can try and peel away, but doesn't look like. It looks like there's a false appearance of some skin there, but I'm really happy with that. Patient can hear significantly better. We've got all the excess oil out. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.